everyone, and welcome to our BOJANA MD podcast. Today, I have the pleasure of interviewing a dear colleague and friend, Dr. Suzanne Fenske, who is the founder of TārāMD. She is a double board certified OBGYN and integrative medicine physician, and Dr. Fenske applies her broad medical expertise to treat a range of conditions. These include perimenopause, menopause, hormonal imbalances, endometriosis, pelvic pain, PCOS, and she uses a functional and integrative medicine approach. She's passionate about empowering women to take charge of their health, and she provides incredible integrative care for women's health, including gynecological conditions and hormone replacement therapy. I absolutely enjoy having conversations with Dr. Fenske and discussing the different nuances around hormone replacement therapy, and just really so appreciate her approach and her level of expertise in this topic, which is why I, am so excited for her to share this with you guys. And I'm really excited to kind of dive a little bit deeper into hormone replacement therapy, some of the nuances, the dosing, the testing, and so forth. So welcome, Susie.
Thank you. Thank you for having me.
So let's talk a little bit about, HRT in perimenopause and menopause. We've heard this time and time again, right? That as the Women's Health Initiative, the WHI study results first came out in the early 2000s, right? There was a huge shift from prescribing hormone replacement therapy to then suddenly we stopped prescribing it. And those of us that went through our medical training during this time were not even taught these skills, right? And I think that by now, a lot of the audience has heard this over and over again, so we're not going to regurgitate too much on that topic. But in the last few years, certainly there has been a lot more media attention, a lot more awareness of women's health, and awareness of really the nuance between that risk and benefit of HRT, and recognition that if we're using different forms of hormone replacement therapy, or now called menopause hormone therapy, that can significantly impact the level of risk and the level of benefit. There's also something we call the timing hypothesis, which, again, depending upon the timing of when menopausal hormone therapy is initiated, we may see different benefits and different risks. So let's just kind of dive right in. Maybe for our listeners, if you could share a little bit about your general framework currently. When a patient comes into your office and let's say they're either in perimenopause, so the time of their lives where they're already starting to notice hormonal changes, typically early perimenopause, maybe their cycles are shortening, they're starting to notice more PMS symptoms, or later perimenopause where they're skipping cycles and so on, and already having more of those estrogen deprivation kind of symptoms like hot flashes and so on. Tell us a little bit about what are the things that you consider when it comes to offering them menopausal hormone therapy, and just kind of your general approach, and then we'll sort of dive in deeper.
Yeah, love this topic. So it is, as you said, it is such a nuanced subject. First off, we're starting off with data that we don't have enough data. And oftentimes we're sort of extrapolating. We're saying that, for example, a study that's used one form of estrogen is going to be applicable to the other form of estrogen. So it's an incredibly nuanced topic. And it gets very confusing for, physicians who are prescribing, confusing for women who are trying to make decisions. Ultimately, the most important thing, right, is not hormone replacement therapy or no hormone replacement therapy. Even if you've decided that HRT is the route for you, it is so much more, right? And that's kind of the beauty of what we do, being more integrative in our approach and approaching things from a 360-degree angle on it. When I first see a woman and she comes in saying perimenopause, and it's variable, women are much more knowledgeable now. So a lot of them will come in saying to me, I am in perimenopause, I need help. But there are those women who don't even still associate their symptoms with perimenopause. So you have to kind of always start with wherever the woman is at, right? And educate first and foremost, and hear and listen to what their symptoms are, listen to what the goals are, which is so important. As a physician, we're so eager and quick to want to fix that we sort of jump in with the assumption that we have an idea, we're going to fix this, this is what we're going to work on, you mentioned this. But at the same time, for me, it's always so important that I always end it by saying, what are your goals? What are the things that you really want to see improved? Because they may mention a symptom that really isn't bothersome to them. And I may, as a physician, as somebody who really wants to help, jump on that. So always it's a conversation. I am fortunate that I have an hour with my patients for a new patient. So I'm able to sit there, hear their story, gather their information, focus on family history, personal medical history, and then go through the pillars that I always talk about, right? What's their nutrition right now? What are they eating in a day? How are they moving their body? Where are their stress management skills at? Talk about sex. Are they having pain with sex? Are they having libido changes? Are they having orgasm changes? And hear that out as well too. And then hear what supplements they're on, right? Because most women that come to me have already sort of listened to this podcast, that podcast, and they sort of are already on this routine of supplements. The problem that I see right now is that we're sort of all under the assumption that there is a one size fits all and that there is a one approach and there are these certain supplements everyone should be on and everyone should be on HRT. So education's always the most important part of the first visit together.
I'm really glad that you emphasize the role of education and then the role of a person's specific goals, because I completely agree with you. Not only can the symptoms greatly range during perimenopause and menopause, but a person's goals will range, their priorities will be different. And we as physicians really can't make assumptions that about what a person may want. And in so many cases, I've had patients who might report some symptoms, but they're actually like, you know what, this is very infrequent. It really doesn't bother me. It doesn't interfere with my life. I'm okay to live with this, versus other symptoms that are like, okay, can we please focus on this? So it really is all about where do their priorities lie, and even making certain connections. One of the things that I think is often overlooked, for example, are the genitourinary symptoms of menopause and the great risk women experience as time goes on with respect to urinary symptoms, urinary tract infections, and so on. And so making that connection with respect to, would they benefit from some vaginal estrogen treatment, which a lot of the times people don't even necessarily think to ask, or physicians don't think to offer. And again, it wasn't until after my formal medical training that some of these aspects of care and some of these goals and topics to talk about really came to light for me as I was pursuing, further training and really kind of aiming to understand this period of life better. And again, what are the evidence-based modalities that we can really use? And as you said, there's no one size fits all. So tell me a little bit about, I think you touched on something very, very important. And again, we'll dive into the specific studies and the specific knowns, but women experience perimenopause and menopause very differently, right? We've all seen patients who come to us with multiple hot flashes, night sweats a day. They have disturbed sleep. They have those like very prominent vasomotor symptoms, which are not only a disturbance, but they also are correlated with actually worse cardiovascular outcomes down the road. But what about the patient that's coming in and maybe their symptoms are very mild? Maybe they're very manageable. Maybe they're very happy on what they're doing with respect to lifestyle, nutrition, and whatnot. Are there any reasons in your practice that you might consider talking to them about HRT, for example?
I mean, absolutely, right? So it is not recommended right now that you use HRT as a longevity aid, right? That's not the indications for hormone replacement therapy at this time. We have associations we're going to dive into about some benefits that do affect from a longevity perspective. But that's not currently. We need more data, right? We need more data on all those aspects. But there will be women that will come in who may have really mild symptoms. I saw a patient this past week, really asymptomatic at this point, but she had a significant family history of osteoporosis with both of her older sisters with osteoporosis. She herself, I strongly encourage to get a bone density scan, kind of going against what the traditional guidelines are when you do your bone density scans, which is a whole other topic that I think that we agree on is not quite right. But that being said, she did proceed with getting the bone density scan and had a diagnosis of osteoporosis at age 50. And her osteoporosis was in the categories of it, talking about the T and Z scores, still a mild case of osteoporosis. But she and I did at that point dive into the conversation because it was in her plan, in her own medical journey and plan, that she did want to go on hormone replacement therapy in the future. So our conversation was, do we initiate this now? Yes, thankfully, currently your perimenopause is quite mild and quite tolerable. But this would be a good agent to consider using in prevention of bone loss, and affect her long-term look at life in regards to risk factors for fractures, and the medications that are used for osteoporosis and the side effect profile with those medications. So there are women, you have to look at the whole picture. There are women you definitely want to use HRT even if they are not symptomatic yet. We'll go into this too. There is some data on women who have the ApoE gene and the prevention of Alzheimer's dementia down the line and initiation of hormone replacement therapy. So that's a conversation that I do have with women too who have a significant family history of Alzheimer's and they themselves have tested positive for the gene.
Yes, yeah, definitely. And maybe just to clarify for anybody who is curious and maybe you're interested in learning more about it. So with ApoE4 gene, so this is, or ApoE4 allele of the ApoE gene in particular is a gene variant that can confer an increased risk for cardiovascular disease as well as dementia. When we see that an individual has one copy of this allele, it can increase their risk of dementia by 2 to 3-fold. And when we see that they have two copies of this allele or this variant, ApoE4, it increases their risk of dementia by 8 to 12-fold. So it's something that, again, I always emphasize to people, genes are not your destiny. There are still things that we can do, but it certainly confers a pretty significant increase in the risk. And so it's something that's very relevant in terms of looking at. So let's dive into, some of the things, maybe just to kind of back up a little bit. And again, for people who are curious, what are the current FDA indications? So currently, we have essentially 3 FDA indications for women that are entering menopause at a typical age, which on average would be 51 or 52 years old. So that's for vasomotor symptoms of menopause, which are hot flashes or night sweats, for genitourinary symptoms of menopause, which can include what you alluded to, whether it's painful intercourse, whether it's vaginal dryness, whether it's urinary symptoms, and so on. And then for bone loss prevention as well. And then for women that enter early menopause, which is not going to be so much the focus of our discussion, it is recommended that they go on hormone replacement therapy because we know that in this population, when they enter menopause before the age of 40, but my understanding is that there's still significant benefits if they enter before the age of 45, which is considered premature. They will still benefit actually from the cardiovascular standpoint and from the longevity point. Some of that data is a little more clear in that population who enter menopause much earlier. So, but then there are all these other correlations and associations that we see that haven't necessarily panned out in the literature, or that are still controversial in the literature. We see some positive studies, some neutral studies, some negative studies. This is all very confusing to a lot of people and clinicians too. So walk us through regarding some of the major studies like WHI, but even some of the studies that have been done subsequently with respect to what are some of the other symptoms that are not necessarily FDA indications for hormone replacement therapy, but when might hormone replacement therapy be considered? And when might it be beneficial? And what are we really kind of lacking in terms of literature there?
Yeah. So again, the literature, we still use the Women's Health Initiative trial and sort of the spin-offs of that in data. So there's, you alluded to this too, but there's the WIMS trial, right? The Women's Health Initiative memory study that actually looked at hormone replacement therapy and its effects on cognitive function dementia. Initially in the women, because again, going back to the Women's Health Initiative trial, they included women ages 50 to 79. So they were able to sort of look at the women who were 65 and older and see the impact of HRT initiation at that point and see its effect on cognition. And there's like you had talked about, there's a few trials out there that look at the impact of HRT on cognition, dementia. And it does. There are some that's just neutral. There are some studies that show a benefit. There are some studies that show detrimental effects, right? So in that trial, in that portion of that trial, in that subgroup population of 65 and older, they actually showed that initiating HRT could possibly increase the risk of dementia and cognitive decline. There was an additional trial where they subset looked at the younger population in the Women's Health Initiative trial, and that was the WMSY. So it's the WIMS with the Y. And in that trial, they actually showed no effect. Right. So there was no cognitive decline. There was no improvement. We do have additional trials that do look at HRT initiation, again, going back to that whole timing hypothesis, which we're going to dive into even deeper. But when we say timing hypothesis, we're talking about sort of the ideal time to start hormone replacement therapy. And this goes back to the Women's Health Initiative trial, right? So when we say we have women involved that are 50 to 79, that is a vast age range, right? You're comparing women who are just going into menopause or just coming out of menopause to women who've had menopause possibly 20, 30 years prior. And that was one of the major issues with the trial. You can't lump all women together from that vast an age range. So the timing hypothesis is that what we're seeing often in these trials is that initiation of hormone replacement therapy as close to menopause as possible, right? So even starting it in perimenopause or starting in within 10 years of menopause, or if you have a woman where she doesn't know where her menopause is because, she had a hysterectomy or she had an ablation. So she doesn't know when her last menstrual period was by the age of 60, sort of the cutoff that's used in that population. That we see benefits in regards to improvement in cognition and dementia is one aspect of the timing hypothesis. We also look at cardiovascular in regards to the timing hypothesis too, but that beyond that age range, potentially initiation of HRT could actually cause harm. Now, it's a huge conversation, right? Actually looking at the numbers, you're still talking about very, very small numbers for dementia risk and cognitive issue risk with initiation of HRT past that ideal population too. So we're not talking about large numbers, right? Even when we're talking about sort of going back to relative risk of breast cancer with HRT too, these are all really small numbers. Stroke risk with HRT, oral estrogen, which we'll talk about too, it's 6 cases per 10,000. So these numbers are still quite small, but it has to be part of the conversation. What we're saying now with the timing hypothesis is initiation ideally of HRT earlier rather than later seems to confer more benefits.
I had a recent conversation with a cardiologist where he was sharing about clearing patients essentially for hormone replacement therapy. And interestingly, his observation too was that there's a lot of fear, even from his end. He said, look, most patients I agree with initiating HRT. And some of the ways that we might estimate, what that risk might be is we have cardiovascular risk calculators like ASCVD or Prevent. We also have the ability not just to check the lipid panel, which goes into these predictive calculators, but also we have the ability to actually do a coronary calcium scan or a CT angiogram where we can assess both calcified and non-calcified plaque. And again, that gives us a sense of that risk. It gives us that estimate of, are we dealing with someone who has healthy arteries, who falls into that early part of the timing hypothesis where we still think estrogen in particular, but both really estrogen and progesterone have that benefit with respect to arterial elasticity and lowering inflammation and so on? Or are we dealing with somebody who already has some arterial stiffness, who already have some plaque, and then maybe there could be an increased risk conferred? And I also always wondered if there was something in addition to the logical increase in risk with pre-existing cardiovascular disease by the time you're 65 versus 50. I always wondered if there was some change downstream in the body that occurs after we've been deprived of estrogen for 10, 15 years, like other than the actual increased risk post-menopause to develop cardiovascular disease. But does introducing that estrogen 10, 15 years out after having been deprived, like does that actually change its downstream effects, and what happens to the receptors? And my understanding is that in the brain actually increases the number of estrogen receptors because of this kind of thought process that we really need everything we can get. We're so reliant on it, but I think it's something that's definitely an interesting area of research of like how does that molecularly, how does that physiologically change the actual effect of estrogen?
Yeah, I always actually wonder, this is, there's no research on this, but I always wonder if sort of part of the aspect of the weight gain that often happens with menopause is that we know that we can make estrogen not just in the ovaries, right? We make estrogen in our fat cells. So it's potentially a way for the body to try to upregulate naturally estrogen.
Yes, agreed. Yes, absolutely. So maybe just to dive into a little bit into the numbers, even from, again, WHI, a lot of the data was interpreted in one way and extrapolated into areas that it didn't necessarily serve us well. But I think one of the things that's really interesting is looking at, that subset of women that are 50 to 59 years of age, because we again have that sub-stratified data, as you mentioned, from the WHI, and really looking at, even though they were provided with hormone replacement therapy that we don't necessarily use as our first choice today, I think extrapolating some of that data is still very helpful. And as you mentioned, if we look at that subset 50 to 59, we're really talking about several cases per 1,000 women per 5 years of use. So
Right.
that is the level of risk we're considering. So essentially less than 1% over the course of 5 years when we look at additional cases of invasive breast cancer, additional cases of stroke, additional cases of blood clots, which essentially are, with respect to the blood clots and with respect to the cardiovascular, it seems that these are not really relevant if women are using transdermal estrogen, which we can dive into as well. But that's really the level of risk we're talking about. We're talking about less than 1% per 5 years in terms of increased risk. And so, but there are also some benefits as well that came out of this study. So let's focus on some of the benefits too. And again, these are all very small numbers, but again, really interesting data.
Right. So, I mean, first and foremost, we know that quality of life is improved, right? So, obviously, vasomotor symptoms have a significantly improved on hormone replacement therapy. That is, the benefit to HRT, again, is instead of piecemealing out the symptoms of perimenopause and menopause and sort of attacking them from different angles with multiple different medications, hormone replacement therapy can sort of be, the one size fits all model to dealing with most of the symptoms that are experienced with menopause and perimenopause. But so obviously, improvement in vasomotor symptoms was seen. We saw an improvement in cardiovascular risk, right? So the decreased rate of heart disease, which is the number one killer of women after the age of 55. We saw decreased risk of colon cancer, right? So this is not brought to light as much, but we saw, and with colon cancer on the rise, this is actually a great thing to know and utilize. Decreased risk of diabetes. Again, using the timing hypothesis, you can have a decreased risk of dementia if started in that ideal time frame, and decreased risk of fractures and osteoporosis. So we see that all those, and there's actually, depending on the data that you're using in which trial, 19% reduction in mortality overall.
Yes, yeah. And what's interesting too on the coronary heart disease component, I'm curious if you could comment on it a little bit, because we see that with estrogen alone, there seems to be this clear benefit, like you alluded to. But then again, in this study, they use synthetic
Right,
progestins, which is
right.
the natural progesterone that our body makes. And so we do think that there's a distinction there. But when they use both the estrogen and the progestin, that risk did go up a little bit. How much do we know when we're using, oral micronized progesterone, or, there are certainly other options for progesterone that we can talk about for endometrial protection that can be used that wouldn't necessarily confer this increased risk. But do we know anything about the oral micronized specifically when that's used together with estrogen for coronary heart
We
disease?
know very little. Most of our data really does look at, conjugated equine estrogen and the synthetic progestins. That's what most of our data was and is. The hope now is that with sort of, bringing HRT back onto the playing field, whether we're going to get more data looking at these and looking at all the individual preparations and the impact it has on it. You alluded to it, but what was used in most of these trials was medroxyprogesterone, right, which is a progestin. So it gets super confusing with terminology, but progestins are synthetic progesterone. What's used more commonly now is bioidentical progesterone, and bioidentical just means it's the same chemical structure as what your natural hormones are. There are FDA-approved bioidentical preparations as well as the compounding, but there are FDA-approved bioidentical preparations. So that's what's come into favor more so now. There are additional alternatives for protection of the uterus, like you mentioned. So the reason ultimately why progestins were ever incorporated into the treatment with hormone replacement therapy initially was that it used to be that they just used estrogen alone, and used conjugated equine estrogen was the initial form of estrogen that was used. And it was used alone, but they saw a slight increased risk in uterine cancer because estrogen acts proliferatively in the uterine tissue. So when we say proliferatively, we say that that means that the more cells grow and rapidly divide, the more risk factor there is for mutations and cancers to occur. So progestins were introduced to protect the uterus. Now, a whole other conversation is, yes, there are benefits to progesterone in and of itself. It can be a wonderful aid for a lot of women. But the reason why really it was incorporated into HRT was protection of the uterus from uterine cancer.
Yes, and this is what I was going to ask you. I'm curious to hear about your personal practice because technically, and again, by the guidelines, right, we should be using estrogen alone in people without a uterus, right? Because we're
Right.
not concerned about that endometrial protection anymore. But as you alluded to, there are a number of benefits that women will have with using progesterone therapy. So I'm curious to hear a little bit more about your personal practice of how do you decide when you might be more inclined to offer it versus not offer it, and what is your approach there?
Yeah, so with there's actually a few subset patients that I absolutely always use progesterone when I'm using estrogen for menopause hormone therapy. For women who've had a history of endometriosis and those women who have had hysterectomies, for example. So technically, yes, they can just be on estrogen alone. I always use progesterone in these women as well, right? Because there are women who can get recurrence of their endometriosis symptoms if they're on estrogen alone, right? The mechanism of action in regards to endometriosis as a disease process is that it feeds off of estrogen. So if you give estrogen alone, you can have that risk of that happening for a woman who's now postmenopausal on hormone replacement therapy. So I will always use progesterone. There are times actually in early perimenopause where I will just use progesterone as well, right? So going back to sort of looking at the stages of perimenopause and sort of that early transition period with regular menstrual cycles, and a lack of those estrogen deficiency symptoms, really more of a focus, like you alluded to, on potentially a shorter cycle, a heavier period, worsening PMS symptoms with more rage, water retention, weight gain, then sometimes actually cycling progesterone during this time can be a really helpful aid because the way that progesterone is made is that it's made by that corpus luteal cyst when we ovulate every month. So as we get older and our ovulation is, not functioning the way that it used to, then it's not the production of progesterone isn't as robust. So sometimes these women actually benefit from having progesterone. In regards to sort of the standard patient of perimenopause and menopause, even if they don't have a uterus, but they're having, significant anxiety issues falling asleep, progesterone can be a great aid for helping with falling asleep, initiation of sleep, Estrogen tends to be better with sort of that waking during the night that women will have, but progesterone can be really helpful with falling asleep. It activates the GABA neurotransmitter in the brain, so it's really calming. It has a kind of a natural calming effect. That being said, right, there's about 10% of women who actually don't respond well to progesterone. And with that, it's sort of this paradoxical response where you'll give them progesterone, they'll call you the next day and saying, I was up all night, I was anxious, I was ragey, I'm a mess. So there is, if you're one of those women who's going through it and you're like, oh, my friends love progesterone, this goes back to what we said initially, it's not a one size fits all model. And that goes across sort of the whole space with perimenopause, right? There's also kind of this wave to go against even using birth control pills. And there is a time and a place for birth control pills. There is a time and a place for using oral estrogen. There's a time and a place for using transdermal. There's a time and a place for using even the original conjugated equine estrogen. It should be very individualized. But those are just some instances of when I will use progesterone.
Mm-hmm. What about, again, based on WHI, there is some reduction in risk of breast cancer if you're using estrogen alone, but then an increase if you're using progestin. But then subsequently, we have more data from subsequent studies that looked at using oral micronized progesterone, which is our, first progesterone of choice, right? And there's some data suggesting that if you use it up to 5 years, there's actually, and potentially even beyond, that there's actually no increase in risk of breast cancer. So might you, in people who are higher risk of breast cancer, and again, for people who are interested in assessing their own risk, there are online risk calculators that you can do based on your family history, based on your menstruation history, childbearing years, and so on. And so the IBIS questionnaire is a great one that we'll use. But let's say somebody has that higher risk. They don't have a uterus for some reason. Would you automatically have them on estrogen only? Or if they're experiencing some of these symptoms like sleeplessness, irritability, or whatnot, might you try them on a low dose of progesterone? And assuming that it's oral micronized, we're thinking that maybe we're mitigating that increased risk from that original study.
I mean, absolutely, if they're having those symptoms. But there are those women that, for me, who are kind of that higher risk profile for breast cancer, that I will actually kind of go back to the originals, right? So I will talk to them about the benefits of considering oral conjugated equine estrogen. There is actually a medication on the market that combines oral conjugated equine estrogen and a selective estrogen receptor modulator, a SERM. And for those women who actually really are more at high risk, but they are having debilitating symptoms, and quality of life is quality of life, right? I will actually talk to them about using that medication, because the combination of those two together, we have the data from the Women's Health Initiative trial where conjugated equine estrogen alone, we saw a slight decreased risk of breast cancer. And then combining it with a selective estrogen receptor modulator that will take the estrogen and direct it away from the breast tissue, away from the uterine tissue, and towards the areas we want it to go to, right? The brains, the bones, the heart. Mm-hmm. I will actually talk to them about that too. Of course, with that, right, everything's a risks benefits conversation that will confer that slight possible increased risk of stroke and blood clot, which mostly happens in the first year of use, and that rate does decline in subsequent years. But that's actually one of my tools that I will talk to them about.
Yeah, I agree. And again, just goes to your point to show that there is really no one size fits all. But with each therapy that you're considering, there's always going to be that different risk benefit to manage. And it's really, that's why we say, so much of the Menopause Society guidelines and so much of what we do in clinical practice is shared decision-making, shared informed decision-making, because there is no cookie cutter approach here with respect to dosing, with respect to formulations, with respect to kind of all benefit, no risk. So it's managing that risk. Or if somebody is at a particularly high risk of blood clots or stroke, then making sure that you're using the formulation that's not oral and that's going to not have those effects in terms of clotting factors and so on. So really kind of looking at what are the greatest risk factors based on one person's family history, what are the symptoms we're dealing with, and then how do we best match up the specific formulations. I think this is really great in terms of kind of like sharing, a little bit more about your framework. Tell me a little bit more, how many, because, that 10% or so of women, right, that don't tolerate that oral micronized progesterone, right? So let's talk a little bit about vaginal progesterone, about progestin IUDs. Tell me a little bit about, how often do you see that women are having to switch to those options, and a little bit more about kind of what we know about that.
Yeah, so I mean, in regards to uterine protection, we don't have actually great data. There's actually no studies looking at using the progestin IUD for uterine protection for menopause hormone therapy. But what we're using is that it is actually a known treatment for treatment of endometrial hyperplasia, right? Precancerous lesions in the uterus. So we sort of extrapolate that data onto the benefits in regards to protection of the uterus if you're on hormone replacement therapy as well. But for somebody who doesn't tolerate oral progesterone, you can take that same pill and put it vaginally. And get the uterine protection. And then oftentimes, because you're not getting that sort of systemic side effects, it's well tolerated that way, and you still do have the uterine protection from that. Another option is, again, using the progestin IUD. But again, that's using data that's assumptions in regards to endometrial hyperplasia. And then the third option is using those selective estrogen receptor modulator. The unfortunate thing is that that SERM is always in a combined with the conjugated equine estrogen. So they don't have that SERM as an option separately to be utilized to offset estrogen. So it kind of has to be an all-in-one package on that one medication.
Right, right. And what about women that are still having symptoms of genitourinary symptoms of menopause and they're on systemic hormone replacement therapy? How often do you find, number one, that that's the case? And number two, let's just bust the myth that, they can be on additional vaginal estrogen as well if needed.
Yeah, I mean, so the data shows 20% of women who are on systemic hormone therapy still have genital urinary syndrome of menopause. And that, again, to highlight on it, the symptoms are vaginal dryness, pain with intercourse, frequent urinary tract infections. I can't tell you how many women are like, I haven't had a urinary tract infection since my 20s, and all of a sudden I've had three. So frequent urinary tract infections, urinary frequency in general, right? So a lot of women will come in saying that, oh, now I'm getting up in the middle of the night to urinate, but I'm on a health kick now and I'm hydrating. And no, this is all part of the genital urinary syndrome of menopause. So with the declining levels of estrogen in the vagina, the tissue becomes thinner. There are receptors for testosterone and estrogen in the vagina. So with those declining levels of those hormones, these are the impacts that we have. There's decreased blood flow to the area. There's decreased collagen production in the area. There's decreased hyaluronic acid. So all these symptoms kind of come into play. That being said, even though the data says 20%, I actually in practice think that that's actually very low. I think that's actually not quite accurate. My experience is that significantly more women still have symptoms regardless of being on systemic hormone therapy. And there's different options. In practice, my experience is a little bit different than what we sort of see, but there are estrogen, right? So estradiol is one option that's used. Estradiol, they can come in tablets, in cream. Um, there's prasterone, which is vaginal DHEA, essentially that converts locally to estrogen as well as testosterone, and that has a little bit of an extra kind of studied benefit in that we do see that it has an impact on stress urinary incontinence and libido as well too, and that's part of sort of the testosterone aspect of that medication, and that's indicated to be used every single day. It's a softer suppository that's put in the vagina every single night. Your estrogen cream or your estrogen tablets are usually used initially every single night for 2 weeks and then twice a week.
After that, yeah. And let's now talk a little bit about, so a woman comes to your practice, you are going to start her on hormone replacement therapy based on some of these indications that we talked about. And we can break it up into two scenarios, but still kind of keep it fairly general. let's say you have a woman that's coming in, she's not on any kind of birth control, she is not taking anything, but starting to have these symptoms, let's say vasomotor and some other symptoms of menopause. And you have the other woman that's on oral contraceptives. She's, let's say, at that average age of menopause and asking you, well, when should I be transitioning to menopausal hormone therapy? What dose do I go on, given that I've been on these oral contraceptives, and that's quite a bit higher dose than menopausal hormone therapies? How do you kind of think about that? And are there specific starting doses that you might consider in one patient versus another? Again, assuming that there are no absolute contraindications to using it. So this is assuming that, you're greenlit with respect to the risk.
Right. So if I have a woman who's still getting her cycle, not on oral contraceptives, getting her cycle and has symptoms, but still has a regular cycle, then oftentimes I'll start my dosages low. And often that's all that's needed during that time. It's just kind of covering the bottom. So the important thing to understand is the difference between OCP, oral contraceptive, and menopause hormone therapy, right? As you alluded to, the dosages are significantly different. Menopause hormone therapy is much lower dosed, and obviously, very often is bioidentical, and the oral contraceptives are synthetic hormones at a much higher dose. So their effect is going to be that they will turn off the ovaries and give a steady state of hormones. Menopause hormone therapy will not turn off the ovaries, right? So what you have to do expectation wise is understand going in, your cycle is still going to do whatever woman's cycle is going to do because it's not impacting at the level that an oral contraceptive pill is. So if I have a woman who comes to me with initially, say, her symptoms are that she's having significantly heavy periods, as well as other symptoms in regard to perimenopause, but that the cycles are really debilitating and really affecting her life because they're so heavy. And so irregular, say, if another woman who is very irregular, then at that time, even though a lot of people will frown upon this, is a birth control pill can be a great tool to use during this time. If I have somebody who's regular menstrual cycles, but having the symptoms, then usually I'll start my hormones at lower dosages. If you have somebody who's coming off of a birth control pill, this is a very tricky scenario because you're not quite certain where she is. Now, interestingly, even for me, and having done this for as long as I'm doing this, I was always under the assumption that if you're on a birth control pill, you will not have symptoms of perimenopause. And I'm still flabbergasted by this, and I can't find information in regards to anything on this. When you do your deep dives, you can actually you can guess, right? You can kind of use your 2 cents to try to figure it out, but it doesn't make sense that women, in my mind, right, that women actually would have symptoms of perimenopause. But time and time again, I will have women come in to me and say, yeah, my mood is awful. All of a sudden, I'm waking at night. I'm having this, I'm having that. Anxiety is really kicking in all of a sudden. And it is their perimenopause symptoms coming in. And I do wonder, I do wonder if it's the difference between using the synthetic ethinyl estradiol that's in most birth control pills versus having the estradiol that's in hormone therapy. But I don't in regards to that. But in the woman who's on birth control pills and say that she is, further out, right? Because the guidelines now say you can be on a birth control pill until age 55. So if they're further out, right? If they are in fact coming off of the birth control pill further out, oftentimes they will need a bit of a higher dosage, which will then have to be tweaked. They may have some of those sort of higher levels of estrogen side effect with that, but oftentimes those women do need to be put on a higher dose hormone therapy because you will actually bring on even worsening of their symptoms of perimenopause, dropping them so precipitously from these high doses of hormones that are in birth control pills to these much lower doses that are in hormone therapy.
So let's say then if you're converting them from oral contraceptive to menopausal hormone therapy, and let's say you're using a transdermal estradiol patch, then you might go to the zero point 0.1 milligram, let's say, patch, or so put them kind of at the very high end of the range. But what about those women that are, let's say they're in their late 40s, early 50s? So technically they could still stay on the birth control pill. They're not at that 55 year mark, but they're having those breakthrough symptoms. Is it safe to give them additional hormone on top of that? Or do you still try to switch them because of that point you made about, the conjugated equine estrogen orally versus the transdermal? Or how do you manage those breakthrough symptoms when I agree with you. I see this too. But you wonder, okay, well, why is it happening now if their ovaries have been suppressed this whole time?
Hmm. I mean, I usually end up taking those women off of their birth control at that time and putting them onto menopause hormone therapy.
Mhm.
And they're usually much happier that way. It would be something, obviously, if there's somebody who really wants the contraception or need the contraception, then that is a whole different conversation. There are other things that I do use a lot now in regards to contraception that we're very fortunate that are fairly new to the market that can avoid hormones without having, an IUD. There is a gel now that's being used that you can put in the vagina even up to an hour ahead of intercourse. That's about 93% effective for contraception that a lot of women do like during this perimenopausal time period where they don't want to be on hormone contraception anymore. But they're obviously, their plan is not to get pregnant at this time.
Yeah, and you're talking about Phexxi, I assume. Is that?
Yeah,
Yeah,
Bexy,
yeah, yeah.
Bexy.
Great. Let's talk a little bit about blood work, right? So,
Mhm.
guidelines again tell us don't check blood work, really be guided by your symptoms. And I also find that I always tell patients I'm not treating the labs, I'm treating you, but I like to use labs as an adjunct, again, depending on the case, with respect to just giving me a little bit more information. And in this case, it might shed some light um, on what are their levels where they're typically feeling their normal self but again, there's a lot of variability here. And again, you and I'm sure we've both been in conferences where one speaker says I do blood testing, another speaker says I do urine, another speaker
Yeah.
says I use salivary, and all of these different modalities are actually showing us a glimpse into different aspects of the absorption or the levels. But I'm curious to hear, what do you do in typical practice, and how do you use these numbers, if at all, to determine, does anything need to be tweaked? Is the patient responding the way I would expect them to, or do you eliminate the use of labs for the most part?
No, I've always been a lab person. I do. I'm a data person. And I think that, I think it's interesting that we give thyroid hormones and check labs, but we give, and honestly, men who are on testosterone replacement oftentimes have their labs checked. So what's the difference in regards to this?
Mhm.
For me, also, the other factor is that I don't just look at as I'm sure as you don't either, at estrogen and progesterone, right? First off, progesterone on blood work is not a great way to look at progesterone, but it's really important to me to look at the other hormones too that are all part of it, right? We're not just estrogen and progesterone. So I like to look at the testosterone free and total. Um, and I'll do an LCMS when I do that. I like to look at DHEAS. I think it's incredibly important, DHEAS, to kind of look at in regards to especially those women who are reporting fatigue, right? A lot of women during this time, fatigue is a big thing. And yes, estrogen has a huge role in fatigue and can often, in and of itself, really fix that symptom. But oftentimes I see DHEA, right? And it all comes into play that fluctuations in your sex hormones have a significant impact on your adrenals, right? Your adrenal glands are your fight or flight type of glands. They're the ones that secrete the cortisol. And if they're sensing and signals from the body of stress, which the fluctuations in hormones cause, then you can see that also in regards to DHEA, which is it's excreted by the adrenal glands. So I like to look at the whole picture. I also, just because women like to know this, will look at FSH levels too, even though very often FSH is normal until either the very end or menopause itself. But it's just sort of a metric to be able to give to women as well. I tend to do blood work in regards to that and do that. There are tests that I will do sometimes, right? Like I will do the urinary test that looks at hormones. I prefer personally, if I'm going to do that sort of extended test, to do the urinary one because I actually like to look at the metabolism pathways and see whether or not women are breaking down their estrogen well, right? So when we give hormones, it's not just enough to give the hormones, but you want to make sure that a woman's going to do well on the hormones. And the metabolism pathways, when we break down estrogen, are that we break down estrogen in the liver, for phase 1 and phase 2, but then phase 3 is in the gut, right? So you want to make sure all those things are in good order. And that's kind of the benefit of the integrative functional side of things, in addition to the traditional side of things, is having that knowledge. So if you have someone who comes in who really has significant bowel symptoms at the time of their perimenopause and menopause, where they're having a lot of new onset constipation, bloating, then it might be important, right, to look at their gut and see what's going on in their gut, and make sure that that phase 3 metabolism process is also going well too. Because in phase 3 of estrogen metabolism, when there's a beta glucuronidase is used during the metabolism process for phase 3, and if beta glucuronidase is high, then estrogen is actually going to recirculate back into the system. So now you're giving a woman hormone therapy where she's getting her estrogen, and this metabolite is now coming back into circulation and being active as well, which can lead to a lot of breast tenderness. It's always funny, the estrogen deficiency symptoms and the estrogen excess symptoms can sort of cross correlate, which is why I also like the data. A woman can come in saying she's having a lot of anxiety. Let's use anxiety as an example. But you can have a lot of anxiety when there's an imbalance and it's too much estrogen, as well as there's an imbalance and there's too little estrogen. So it's all part of using it together. Like you, symptoms and their story is first and foremost to me, but being able to kind of piece it all together and be a bit more precise and making it an easier pathway for the woman, you do use all of these things.
Yes. And just for anybody listening too, just to share with them a little bit about the DHEAS that you alluded to on labs. So this is a precursor hormone that's made by the adrenal glands, and it converts into estrogen and testosterone. So you talked about giving DHEA vaginally, which can have great benefits for that genitourinary syndrome of menopause. I want to ask you in a little bit about what your thoughts are on oral DHEA. There is some evidence that giving it orally can help improve energy levels in people with chronic fatigue. But it's generally conventionally not recommended. But I'm curious to hear in body composition benefits and so on. So I think this is an interesting supplement to kind of follow and look at. But again, the concerns are that this can convert. So we want to make sure that dosing is appropriate if somebody is using it and so on. The second point that I have a question about is, are there any particular ranges that you're really shooting for when it comes to that estradiol level on blood work, as well as that FSH level that tells you about, again, because FSH tells us about that feedback loop to the pituitary, that tells you, okay, it seems like the estrogen levels on the whole are sufficient, right? Because when I think of FSH in menopause, I think of looking at thyroid stimulating hormone. I think of looking at, again, it's produced in the pituitary, but it tells us about the feedback loop of, is there sufficient thyroid hormone in the body, right? Whether we're giving it or whether our body is making it. So I'm curious to hear, again, even though it's recommended not to check, but what kind of data does this give us about sufficiency and really meeting that need?
Yeah, so for FSH, to your original question, the ranges that I ideally look for usually are more applicable for estrogen in postmenopause, right? So because there's a lot of fluctuation of estrogen during right? And depending on when they're ideally doing their labs too, is when you factor that into play. Especially in somebody who's perimenopausal, with their cycles being slightly irregular, they may ovulate at a time when you didn't expect them to ovulate, and you may see a high level of estrogen on that lab that doesn't quite make sense, but it's because they had an ovulation at that time when estrogen surges. But for postmenopause, yes, I mean, there is a kind of a range that I use as a marker, ideally between 30 and 100 is usually where I like the levels to be for estradiol. For FSH, if I'm tracking it, then we know that two values greater than 6 weeks apart of 25 or higher, really does kind of support, because we already know what's happening, right? But support the diagnosis of perimenopause. For DHEA, S in blood work, and the supplement itself is actually DHEA. It's not DHEAS, but DHEAS in blood work I generally do find that women do well if their DHEAS levels are 100 or greater, right? Within reason, right? If DHEAS is too high, then you can get more of that conversion to androgens, and then they'll come saying that they are having acne, and those kind of that side effect profile related to androgen excess. But I do actually personally supplement DHEA when I see the levels to be low. When we talk about the conversion process, my concern in regards to it converting to estrogen and testosterone, if their levels are super low, then I'm less concerned about that, right? If they have DHEAS levels that are, 300 or greater, that is not somebody you want to give DHEA to, even lower than that. But because yes, that excess could really actually cause much more of a side effect profile. But the DHEA and DHEA, just for an understanding, is that it does naturally decline with age. This is a hormone that does naturally decline with age. But I do notice a huge improvement in regards to their vigor, vitality, their energy levels when their DHEA levels are optimized. And when I see levels that are less than 100, and they do get that DHEA supplementation, and there are times, right, I don't necessarily use, most often actually, I don't use sort of that standard dosage that's used in a supplement of 25 milligrams. There are smaller dosages that you can get supplement wise. I don't think it's a supplement that somebody just kind of listening or reading an article should go and put themselves on. I think this is a really important supplement. I always think it's very interesting, right, that when you use testosterone, it's a controlled substance, but DHEA is a supplement that you can just get. So it is not something that listening to, for example, this podcast, you should go and just put yourself on. It is really something that should be only utilized if your levels are showing deficiency, and then potentially help with the remaining symptoms, even when you're on estrogen, progesterone.
So you will use it while a person is on estrogen and progesterone in
Yeah.
conjunction with that. Got it. Yeah, yeah. And I absolutely agree. My understanding is that it is actually a controlled substance in Canada,
Oh,
but not in the US. In the US, it's available, and I think it absolutely needs to be monitored if it's used. The dose needs to be appropriate. The dosing in women will generally be different from dosing in men because, again,
mhm.
of that testosterone and the conversions and so on. So it definitely is an area where we need more regulation, and we need more of the providers really being able to support that decision making. Um, but it is interesting. Sometimes I find that when I use the DHEA, I'm also like you. I also generally start with lower doses, and then again I do monitor for DHEAS, estrogen or estradiol specifically, and testosterone free in total. To make sure that there hasn't been this excess conversion, and of course for symptoms, right? But what's interesting is that I find at those low doses, sometimes it's really difficult to tell if people are benefiting. Sometimes people report benefit, other times they feel no different, and so we might work our way up. But I'm also really cautious with it, again, because of those potential risks and so on. But we do have some data that at higher doses it can help with body composition, it can help with bone, and so forth. Um, okay, so you share the ranges with us, which I think will be really helpful for people. And just to really kind of emphasize the urine testing, and then also the stool testing that can be really helpful. So one of the things that I think, both you and I look for when we have women who are on menopausal hormone therapy, or women before menopause or during perimenopause when they're still making their own estrogen, is how are they doing with respect to that detoxification, and how are they doing with respect to those estrogen metabolites that we can see in urine. And while we look at several different metabolites, the one particularly that we get concerned about when it's elevated is that 4-hydroxy-E1. And so this is one of the pieces of information that can give us a clue with respect to, are there these so-called toxic metabolites, potentially carcinogenic metabolites that are being produced in excess, that could potentially be associated with DNA damage, that could potentially be associated with hormone-sensitive cancers. So that's one big one that I think we both do. And then the other piece, that beta-glucuronidase, it's so fascinating for me to see the ranges of this enzyme on stool tests. And, we do know that if those levels are elevated, again, particularly in women who are on hormone replacement therapy, we know that there's just this recycling. And I think it's really fascinating and interesting with perimenopause. Like there could be these paradoxical symptoms occurring based on different cycles where we might see very, very high levels one cycle and then very low levels another cycle. So I think it's, again, helpful to track that and helpful to have these additional pieces of information. But I think we're very similar in our approach in that we use this information as an adjunct, but at the end of the day, we're still treating the patient, and we really synthesize that information together. So let's say, just to kind of close off our discussion, there's always so much
So
more that
much.
I could ask
Yes.
you. But to close off our discussion, there's a lot of difference in opinion, again, with respect to hormone replacement therapy cessation. So when should we really be stopping? So let's say somebody starts at the appropriate age, right when they're entering menopause or in perimenopause, and now they've reached that age of 60. There has been some recent data, and we have data from before as well, actually, but there has been some recent data too with respect to, what happens when a woman is in her 60s and what percentage of those women, when we pull them off of hormone replacement therapy, are going to have symptoms. And is it safe if they're still symptomatic, if they're still benefiting, let's say, with respect to reducing risk of bone loss and so forth? What is that? Again, risk benefit equation that you think about, and what does the data and clinical experience tell us about, who can stay on this, what percentage of women actually stay, what percentage of women should probably be staying on it, and then how do you monitor them? Do you monitor them any differently? Because again, at an advanced age, there's going to be an inherently higher risk.
Yeah. I mean, so during even in my early years of practicing medicine, I actually was one of those people that if I gave HRT, I said, you have 5 years. You
Mhm.
have 5 years and that's it. Unfortunately, that was sort of the education that was given at the time, and, to use it very sparingly. And if you're going to use it for 5 years. But we are having more data that came out. There's a trial that came out 2024. I think it was February 2024, actually, but that came out showing that they followed women who were on hormone replacement therapy past the age of 65. So they had initiated obviously during that sort of ideal time and continued on with it and had the continued benefits in regards to decreased risk of heart disease, colon cancer, osteoporosis, fractures related to osteoporosis, and possibly dementia too. So we do see that the benefits do continue past that age group. I think this is also a very nuanced topic. I do tell my patients that, you can be on hormones forever. How my monitoring changes is not that significantly, right? We're still doing breast imaging every single year. For my subset of patients who have, sort of higher risk factors or extremely dense breasts, then we'll usually add in an MRI. So do a sort of a Q6-month cadence of either mammogram, ultrasound, and then MRI. But for the general population, just mammograms yearly are still going to be the same screening techniques. In general, just sort of the trajectory of breast cancer is that it does increase, right? The risk for it does increase with age. It's going to be really interesting down the line to get data looking at breast cancer risk for women who have been on it long term and whether there is actually a decreased risk or an increased risk or no change for continuing on HRT. That's actually a study I can't wait to see as we're encouraging women to stay on it for longer periods of time.
And one final question, I lied before, but one final question ask you is, in what percentage of patients do you find testosterone is beneficial? And acknowledging that testosterone is not approved by FDA in this country for treating women, it is in Australia, and it is endorsed by the Menopause Society for treating symptoms of low libido, right? So, and we have some evidence for this. But I'm curious, I know this is like a very big topic, but if you could just tell us a few words about, when you use it, what proportion of women do you think benefit from it, and that sort of thing.
Yeah, so I mean, libido is a huge topic, right? There's a expression that I always talk about, actually. I spoke on a previous podcast about it, but back when I first started sort of talking on this topic on libido and female sexual arousal, there was an image that I used to put up, right? That was a picture of these two robots, right? And basically the female robot was like, a pilot's dashboard, right? There was just a whole bunch of buttons for libido. And then you had the male robot, and there was literally like an on-off switch, and that was it on that robot. So, and it's true. Unfortunately, libido is such a complicated conversation, and there's so many elements that come into play, especially during this time period, that affect libido. So yes, a lot of women will get their information from social media and so on that, come in saying that I want to be on testosterone too because my libido is an issue. And this is going to be the treatment, the cure all for it. And it's so important to understand going into that conversation that libido is affected by so many things. I mean, during this time period, women are just a lot, busier too. There's family, there's work, there's so many factors coming into play that can affect the ability to even focus on that aspect of your life. How you feel about their changing bodies during this time too can affect it. And then obviously there's the nuances of the relationship itself, right, too. So testosterone is just one small piece of this huge puzzle. I do use testosterone replacement therapy in my practice. In my own practice, I do not do pellet therapy. I tend to compound this. My sort of type A personality, yes, you can certainly do the prescription sort of male testosterone that's FDA approved for men and say to women use, a small percentage, pea-size amount, 1/10, whatever. I personally am a bit of a type A person, and that seems really what is the right word? Inaccurate to me. I want to be able to know exactly how much they're getting. And if I'm going to tweak that, I want to know exactly what I'm going up to or coming down from. So my personal practice is that I do tend to compound testosterone if I'm going to use testosterone. If somebody has a normal female physiological testosterone ranges, and normal being mid to normal range, then I don't use testosterone replacement therapy. And I have that conversation that libido is much more complicated than just testosterone being there or not being there, and kind of dive into those factors of what's going on in regards to their libido and try to go deep and figure out what the cause is. But there are women, right? And I even have women who are younger in their 30s with testosterone. Testosterone does start to naturally decline starting at age 30, actually. It tends to be a gentler decline, but there are some women I will have in their 30s who come in with testosterone levels that are, on total testosterone less than 3, and free testosterone, less than 0.3. So that really is, a cause of their libido. And we do know that there are other benefits to testosterone too, right? We do know that it obviously affects the ability to maintain and put on muscle mass, cognition, mood. So there's other factors for it too. So when you see these sort of abnormally low values, I will utilize testosterone, and oftentimes it can be very beneficial to them.
Thank you so much, Susie. You're such a wealth of experience, and I really appreciate you coming on and talking about this. Hopefully we can have you back to talk more about some of the areas we haven't covered.
Thank you so much. Thank you. Appreciate it.
All information in this video, including but not limited to the video itself, the audio, text, graphics, images, and other material contained in this video, is strictly for informational purposes only. The content is not intended to serve as or be a substitute for professional medical, pediatric, or psychiatric advice, nor is it designed to suggest any specific diagnoses or treatment. Please always seek medical advice from your physician or qualified healthcare provider regarding any medical conditions, questions, or treatment, particularly before making any changes to your healthcare regimen, medications, or lifestyle habits. Never disregard professional medical advice or delay seeking help from a healthcare provider due to something you have heard, seen, or read in this video or audio. Reliance on any information in this video or audio specifically applied to your own case is solely at your own risk.